So I'm Bill Cavers, and I'm back. You lucky people. And actually, I'm Gary Mazzoid. I only fantasize about being Bill Cavers. That'll make up for all the times he gets me. Anyways, it's my great pleasure to moderate this session. And I think, we were just chatting prior to the session, because there was so much interest in questions and engaging in dialogue. I think we're going to try to truncate a bit some of the panel input and invite the audience up early for questions. So please. Please start to think about your questions. So we have a distinguished panel here. I'll introduce them as they come up to the podium. Is the slide changer working? There we go. Sorry, let's just go back here. So this really is intended to be a dialogue about collaboration, and well, I guess we've lost a slide here. Collaboration, I think is the evidence is clearly emerging, and I think some of the strongest signal, I think, about the value of collaboration actually comes from the Canadian Medical Protective Association, which 10 years ago wanted nothing to do with collaboration. Doctors should be doing what they do, and nurses should be doing what they do, and everybody else should be doing what they do, and there shouldn't be any, really, as little crosstalk as possible. And I guess from an insurance standpoint, it's easier. But the evidence is accumulating. There's lots of successful models, and it's such an intuitive concept, collaboration. It is messy business, though. We can't think of it only as horizontal, which I think in many respects we as practitioners operate in that paradigm, because it's also collaborating up and across and down and out. It goes beyond intra-profession. And it goes beyond within a given sector, and I think we're seeing that more and more. The role and scope issue is an interesting one. It's you'll hear some people say, well, in order to collaborate, we better understand exactly what we do, and we better have boundaries and parameters around those competencies. On the other hand, we hear other people who say collaboration really is an opportunity for people to expand their horizons and their skill sets. So the whole issue of scope fuzziness, I think, has yet to be resolved. And of course, it's important to have reimbursement models that support collaboration. Tribalism is a big issue. I like to think we're getting beyond that, starting to get beyond that as more trust develops. One of the intriguing dilemmas around collaboration is perhaps the potential uncertainty around locus of responsibility. And when you hear system change experts talk about collaboration, this is one thing that they make fairly clear, that it seems to be of benefit to have a clinical locus of responsibility, so that at the end of the day, the team, the patient knows not so much who the final arbiter is, but who pulls things together and takes ownership, whether it's in a legal sense or a clinical sense. We also have a lot of words for collaboration, because all of the words that you're seeing on the screen, in one way or another, really are proxies for the kind of collaboration that we have to do. Some of you may have heard Dennis Codnor when he was here a year ago. He's an international fellow with the King's Fund, and he's quite a well-known and respected speaker on health system change. And he likes to say that collaboration is both the glue and the grease of the system. It holds the different parts together, and yet it allows those parts to have the kind of slippage that they need, so they can each do their own thing and yet work together. He also makes the observation that collaboration really needs to start at the patient-provider interface. And the last thing you do is you start to change your higher level governance and organizational constructs and structures. And he always quotes the Cowardly Lion from The Wizard of Oz. He says, what you need more than anything is an abundance of courage. And I think it's absolutely true. Because, I mean, we are on this journey, and it's a journey that is potentially, fraught not only with opportunity, but with some peril. And so dialogue is of absolutely critical importance. So these are the tasks that the panel was given. We're going to ask them, each panelist, to come up and just give 1 or 2 minutes. They have 1 slide each to talk about some of the potential barriers or obstacles or gaps in order to achieve collaboration. And then we're going to engage at that point, I think, both the panel as necessary, but hopefully the broader audience in identifying some of the opportunities. And I suspect it may be a continuation of the conversation that was begun after the last panel. So, at great expense from Fraser Health, we've brought in Mark Pelche, and Mark is the Vice President of Clinical Operations and Support. And so Mark is going to start us off.
Thank you. Green arrow. So the topic I was going to choose just to talk for a minute about was this idea of kind of checking in about shared vision. So in any really big organizational system change, when you look back at failures, a point that was raised this morning was it often has this root in the absence of shared vision. So one of our challenges in this enterprise of both this committee and the partner committees is this idea of kind of checking in frequently enough to check with our core architecture, our core design, our core goals. Are we aligned? And if not, how do we get there? Because if we don't, we're going to find ourselves, a common criticism of ourselves in the healthcare system is that we're a nation of pilots, that we'll have a bunch of pilots, and some very successful. And we need energy and synergy and creativity in those pilots. They need to happen, but we need to be thinking about sustainability. We need to be thinking about transferability. We need to be able to make them happen across the system. So one of the challenges I put to us, put to ourselves, put to you guys as clinicians is to go into that, to carry those 2 thoughts of the micro world, the day-to-day patient experience world, and carry that into systems thinking or carry it into the micro level. So you have to have that conversation. If you find yourself always in that space of thinking about the micro, thinking about the patient in front of you, that's a good thing. That's a good thing. But as leaders in the system, I think you need to be able to say, geez, every week there's a 10-minute space here to talk about the bigger system and to talk to your colleagues about the system. What fundamental assumptions are we making? Are we actually in agreement about whether, in fact, we're moving in the same direction? So the ideal, of course, is this idea that these major players, major organizations, major features of the system are in fact aligned. And the only way that can happen is through dialogue and through collaboration against that idea of clarifying the fundamental goals of what we're trying to achieve to enough of a level of discussion that you're teasing out those assumptions and characterizing it in a way that allows that dialogue to move forward. So shared vision is my point.
Our next panelist is Bob Levy. Bob is a Vancouver respirologist, and he's also been the specialist lead in the Partners in Care shared care project that's going on currently at Vancouver Coastal and Providence Health. Bob?
Thank you. I think there was a typo in the email. You said 1 to 2 minutes. I said 1 to 2 hours, Gary. Okay, well, I'm just going to tell you briefly, I've been involved in some of the shared care work in the province for about 3 years, and I'm going to tell you the most important thing I've learned really around communication. We've learned about a lot of things that can work. We've learned kind of very definitively about a number of things that don't work, and those are just as valuable, so it's important that we share those. This cartoon sort of illustrates our vision of what we're trying to achieve. We have patient-focused care surrounded by specialists and family physicians and allied health, and we're all working together to try and advance kind of the needs for the patient and for all the parties. Now, depending which side you sit on, this is sometimes how the communication is perceived to take place. And depending if you're a specialist or a family physician, you can choose either side, because I think often primary care physicians feel that they're being told what to do and how to manage things and not appreciated. On the specialist side, when you actually talk to specialists, they feel often that they really don't have a good sense of how the ship is controlled. And it's interesting in many of our discussions with the specialist groups that this concept of chronic disease management and shared care really residing the locus of care in the community with the primary care physician, that's not really how specialists are trained. And even the concepts around chronic disease management are very less well developed than they are in primary care. So in this figure, depending on how you look at this figure, starting way over on the left, you can see a source of information, and communication theory really directs that knowledge transfer is received at the far end. So if knowledge transfer is your objective, that little chain works very well. But that line on the bottom that says feedback is what communication is really about. And it's very interesting, in many of the sessions we've had with family physicians and specialists and other allied health and patients, we realize that we're really missing this vital feedback loop. So until we figure out what each other's world is all about, we're not going to be able to provide good shared care. This last cartoon demonstrates a new strategy that's being developed that highlights a new way to communicate, which is face-to-face and verbal communication. I think that what we have managed to find out along the last 3 years, sometimes we've been sort of dragged off in a direction of technology solutions, and it's great to have e-health and telehealth and all these things, but it doesn't replace building the machine with face-to-face communication. And that's what I feel Shared Care Committee has been extremely successful at, and that's getting primary care physicians and family specialist physicians, patients, and allied health with administrators all at the same table trying to understand each other's world. So I'm going to leave you with that thought, because I think we're trying to develop big communication strategies, but it really begins with a conversation around tables like these. Yeah.
Thanks, Bob. Just a couple of comments on, that Bob raised. I mean, certainly from my perspective as a GP in Vancouver, when the ministry came out and really made a value statement that the locus of chronic disease care belongs in the community with the, by and large with the family practitioner, that really had a huge change in our dialogue with our specialist community, initially at Providence and then Vancouver Coastal. It changed the dynamic of the conversation in a very good way. In some cases, some instances it stimulated debate and discussion, but it certainly contributed to a direction. The issue about the telephone, Bob and actually Margot Wilson and I were lucky enough to travel to the Paris IHI earlier this year. And I think they had something like 5,000 delegates at that conference. And there was an awful lot of stuff about technology. But interestingly, there was a groundswell of interest in telephonics. That was the word that was used, actually. And the comments being made were that when you couldn't have face-to-face interaction with a colleague, that the kind of nuanced conversations that one could have over a telephone added something in terms of meaning and significance around a clinical case that you couldn't easily achieve with email, for example. And so I think in the end, I think we're probably going to need a whole range of strategies. So now I'll call on Harriet, who's our patient voice at this table. Thanks, Harriet.
What do I do with this?
Yeah, just push the green button.
Okay, thank you. All right. As you can see here, this is a picture of the Grand Canyon. And I'm going to take you on a bit of a metaphorical journey, which I think illustrates to a degree collaboration and the need for it, and if you're going to have success in anything. We've been talking about collaboration, and I think to bring it down into a form of where we really understand what it means, it's about change. Collaboration is about change that we all feel is important to undertake. And in that movement, it's something that we realize we all have to work together towards. So what comes up on this metaphorical journey where I've got 5 hikers who want to go from the south rim to the north rim? And what do they need to do in order to get there? First of all, a framework. And I'm just going to give you a few things, a bit of a synopsis, but they need a framework. They need to know, what time can I commit to this? The beginning, the end. Who is going to be involved? What are the expertises that they need to bring with them? In other words, skill sets. Are we open to technology? Well, I would sure hope so, because if I was crossing this, I'd want at least 2 GPS. I want to be sure we had really that base covered. Is there a clarity on what it is that we're hoping to achieve? That works through everything, healthcare and all other areas. I don't know how much time I've got left here. Additionally, how invested are the members in this? And I could say from looking at the people in this room, everybody here is invested and wanting to see the change take over. Is there a necessity for a lead? And is that lead a person based on expertise? Is it based on the aspect that they are able to bring people together cooperatively? Is it a decision made by group, or is it a blend of all of the above? And of course, communication. Communication is absolutely essential. And within that particular focus, there comes negotiation and renegotiation. Have you ever sat in a meeting where there isn't an issue, where somebody is putting up another point, another area to be discussed? And that's where it comes into the acceptance that we need to be open to this. We need to be available to change our thinking, or at least expand our thinking, in order to come forth with solutions. Additionally, what would I see as being the biggest obstacle to going across this canyon? It would be a bad attitude. In other words, for success, we all need to have a good attitude, a positive attitude with respect to what we are working on. Without that, it undermines the process. A good attitude brings back around cooperation, it brings in respect, and it brings in a clear path of where we're going to go and what we're trying to do. So I'm just going to leave you with the framework. I think these people, because they were experienced hikers, and they really had wanted to do Mount Everest, but when they found out there was quite a way to push on to the top, they decided no, they were going to do this instead. So we wish them luck, and yeah, collaboration is definitely the way to go. And I've certainly seen it in the shared care committees, and I'm hearing about it all over the place, discussed in a variety of ways, and I think we're all onto something really good. Thank you.
Ministry is Kelly Mcquillan, who's the Executive Director of Primary and Specialist Services. So Kelly, would you like to? Oh, I'm sorry, Kelly. I overlooked our rural physician. Jeff Harries, please. Yeah, Jeff is coming to us with a rural physician voice.
Thanks. I wanted to talk to you a little bit about just sort of the practical nature of shared care. And I think as much as we need to understand that it's needed and we need to be involved in it. There's also many barriers to actually making it happen on the ground. Whether it's, I don't know the name of the mental health worker that's taking care of my patients, so I need to phone someone. That takes time in my office. The person in the ER doc in the emergency department isn't able to contact me directly to talk about what the patient that's presenting in the emergency department. So just really fundamental connectivity between us, and it's not, you know, it doesn't necessarily have to be we're all reading off the same patient charts, although that's a wonderful thing. And you laugh actually, but we actually have that in the South Okanagan to a great extent. We're able to send charts to people and message back and forth, which is an amazingly practice-changing occurrence. But practically, the reason why lots of shared care doesn't happen is because we don't communicate synchronously. So the pharmacist will call me and my staff will take a message and I'll get to them at lunchtime or I'll get to them at the end of the day. That wastes their time, the patient's time. These things, they don't need to be that way. They can be, instead of an asynchronous, so communicating at different times, like in emails, for example, you could actually pick up the phone. The problem is I don't know the respirologist's cell phone number, so I'm not able to pick up the phone and just ask. But when you have that kind of communication ability, things can happen so much more smoothly and efficiently, and I think that's a real barrier to shared care, is how we're all in these different silos of our workflows, and what's efficient for me impairs patients' days and specialist days and the booking clerk at the ultrasound department, and so we're all busy becoming more efficient in our own separate areas that's made everyone less efficient. Thank you very much.
Thanks very much, Jeff. So now we'll call on Kelly Mcquillan from the ministry. Kelly, thanks.
So my potential barrier to collaboration is around the ability of individuals and organizations to create and sustain authentic partnerships. And authentic partnerships are built on relationships and trust, and this requires time. Partnerships in shared care are many. Foundationally, we aim to enhance the relationship between family physicians and specialist physicians and other healthcare professionals to enable shared care for BC residents. This requires many partnerships with GPs, specialist physicians, health authorities, and the people we serve, patients, families, and communities. But partnerships require compatible goals, agreement to do something together, the right people, the right time, doing the right things together. Will, ideas, and a framework for execution for success are required. And with partnership, it implies we're sharing resources, we're sharing the work, we're sharing the risks and the responsibilities. We're working together in decision making, and we're sharing the power, the benefits, and the burdens. It implies give and take. Partnership in the truest sense means we have the ability to establish formal relationships. We can create conditions where partners have their own identity outside of the partnership, are independently accountable to others, as well as the partnership. Actions and transactions will occur, and each party can expect to benefit and agrees to share the risks. A key obstacle or barrier to collaboration is our ability to commit time, resources, and space to create authentic partnerships. And I believe that Shared Care Committee is working to address these barriers. Thank you.
Good. Thank you, Kelly. So the last panelist is Dan McCarthy, who's consultant to practice support and quality at the BCMA. So Dan, the Last word. Last word to you.
Good morning, fellow enzymes. Because that's what we are, really, isn't it? We're trying to affect a change here. When I used to do a lot of debating, and in debating you always have to be able to take either side. And I think this would be very difficult because it's almost impossible to debate against collaboration. It would be a very unique approach. I do recall one of my favorite physicians who retired some years ago and had to say thank you to all sorts of people when he was given some awards. He had particularly said he wanted to thank the patients because without them we would all be redundant. And that has stuck with me in a big way, and I'm glad to see the increasing numbers of patients here today, because they help to target us in a way that nothing else can, and bring us back to a reality. And perhaps the greatest touch of reality today came from Jocelyn, when she spoke about our need for creativity, which is sometimes submerged or subjugated, and our need for dealing with inertia, which is a huge, huge problem, the depression of constant rejection, the banging your head against a wall. And the reason that people seem to support inertia, they're multiple. Sometimes it's self-interest, sometimes it's fatigue, sometimes they've lost their passion. And to some extent Mark talked about that when he talked about the absence of a clear vision for all the players. And I think we've got to really recognize that we, even though we are sort of lead enzymes in this endeavor, there's a lot of people out there who haven't had the opportunities, who work in the healthcare system, who haven't had the opportunities to have meetings like this, to be stimulated by each other, and to develop and reinforce that vision. So I think we have to do that. And sometimes those people in the healthcare system who don't embrace change or don't think there's any chance of change, they're stimulated by fear. And maybe one section of the system creates fear for the others. Maybe people will say, if you don't stay within your budget, that everything is going to incinerate, you will lose your job, you'll lose your house, you'll lose your mortgage, your family, the whole thing. And that's not the way to bring the best out in people, because it makes them cocoon behind the mattresses like gangs used to do. And it doesn't allow them to be that way, to answer Jocelyn's appropriate call for us to be creative and to overcome the inertia and to be appropriately fearless. So doing the same is not acceptable. I will send you, because there obviously isn't time to talk about it too much, there's a fabulous article in the Harvard Business Review this month, in November, by Codnor, who was the king of change, John Codnor. And it says an awful lot of the stuff that I would love to say. So if you please download it. It really is worth reading. And going back further, I was speaking at a Fraser Health thing rather recently, and this brings me back to patients first. And it is, I said that the difference between a hospital and an Irish pub is that in an Irish pub they'll ask you what you want. And I think it was in that Irish pub that I first heard the words of Bob Dylan. Get out of the way if you can't lend a hand. The times they are changing.